Hello, good afternoon. Thank you for joining us today. My name is Lori Smetanka, and I'm the Executive Director of the National Consumer Voice for Quality Long-Term Care. Welcome to our webinar this afternoon. Today, we are going to be hearing about recent research that's been done looking at the relationship between staffing in nursing homes and the COVID-19. The way that's been spreading through facilities and the response to that. So staffing has been a priority issue for the consumer voice, and for 45 years we've been advocating for a staffing standard, for more and better training, for better pay and benefits, and increased RN presence and other related issues for nursing homes, because we recognize that the availability and support for staff is a critical factor in whether a resident receives quality care. What we know is that the COVID-19 crisis has shown an even bigger spotlight on the importance of staff in long-term care and the vulnerability of residents when adequate staffing does not exist in facilities. Research in this area is absolutely essential to identifying solutions that we can build upon, particularly during this time of crisis, as we look for what will be the most effective way to protect residents and staff and to reduce suffering and death in long-term care. And truthfully, we owe nothing less to the more than 56,000 residents and staff who have died due to COVID. Next slide, please, Libby. So I'm very pleased that today we're able to offer this program and hear about some of the important research that's being conducted in this area. After we hear about the research findings, our own Director of Public Policy and Advocacy, Robin Grant, is going to highlight some of the takeaways that we can be advocating for in this area. Next slide, please. Our special guests today are Dr. Charlene Harrington, Professor Emerita of Sociology and Nursing in the Department of Social and Behavioral Sciences, the School of Nursing at the University of California, San Francisco, where she's been a professor since 1980. A gerontologist, Dr. Harrington was elected to the American Academy of Nursing and the National Academies of Medicine. Her research has included, among other things, designing and managing a model California long-term care consumer information system website, studying state Medicaid, home and community-based services programs and policies, and conducting international nursing home research with colleagues in 6 countries. Her recent research has focused on nurse staffing and coronavirus infections in California nursing homes, corporate ownership and financing of long-term care and its negative effect on quality, access, and cost. Dr. Harrington is a member of CMS's Technical Advisory Committee for the Medicare Nursing Home Compare website, serves on editorial boards, and has written extensively on nursing homes, long-term care, health policy, and nursing. She has testified before the U.S. Congress on long-term care research and policy and lectures widely in the United States and internationally. Dr. Yue Li is a professor and health services researcher with major focuses on Medicare policies and quality of hospital and long-term care. His current research includes quality and outcome assessment for nursing home, assisted living, and hospital care, the impact of Medicare payment reforms on healthcare quality, and disparities in long-term care. Dr. Li is the editor-in-chief of Health Services and Outcomes Research Methodology. He's the Director of Health Services Research and Policy Master's and PhD programs at the University of Rochester Medical Center and the Director of Research in the Division of Health Policy and Outcomes Research at the University of Rochester Medical Center. Dr. Li has 20 years of experience with acute, post-acute, and long-term care outcomes and process of care evaluations, has successfully administered and completed multiple NIH and AHRQ-funded research projects related to nursing home care, and has published extensively in leading academic journals. Dr. Li's research has been on COVID-19 infections and deaths. His recent research has been on COVID-19 infections and deaths among Connecticut nursing home residents. A reminder to all of you joining in that today's webinar is being recorded. The recording and slides will be emailed out to participants early next week and will be posted on the Consumer Voice website. You can also find recordings and slides from previous webinars we've been doing on COVID issues on our site. And today's slides and links to the studies from Dr. Harrington and Dr. Li will be linked in the chat box. All of your lines will be muted throughout the webinar. Please post your questions for the presenters in the Q&A box on your control panel. Use the chat feature to make comments or discuss points among yourselves. And after the presentations, we will get to as many questions as we can. So Libby, if you'll move to the next slide. With that, I will turn to Dr. Harrington to talk about her research. Dr. Harrington?
Yes, thank you very much for inviting me today. I'm going to be talking about a new paper that's just coming out in Policy, Politics, and Nursing Practice, where we looked at nurse staffing and coronavirus infections in California nursing homes with my colleagues who are academics in California. Next slide. I'd like to just say a little bit of background information about California nursing homes. We have about 1,200 nursing homes with almost 120,000 beds and about 260,000 admissions each year. The state is spending over $11 billion on nursing homes, and most of that money is paid by Medicare and Medicaid. Over 89% of our nursing homes are for-profit and 75% are chains. Next slide. And I'd like to say a little bit about the background of what's happening in the US before we had the COVID-19 pandemic. First of all, research shows that nursing home infections are the leading cause of mortality and morbidity in nursing homes. And it's estimated that almost 400,000 residents die every year from infections, a wide range of different kinds of infections. And shockingly, 82% of nursing homes had deficiencies for infection control between 2013 and 2017, according to the General Office of Accountability. Infection control violations, unfortunately, rarely receive penalties. So nursing homes pretty much ignore them and are not in compliance and have repeated violations. But in addition to this, 75% of nursing homes did not meet the CMS, Centers for Medicare and Medicaid, expected registered nurse staffing levels based on acuity in 2017 and 2018. So we know nationally we have severe understaffing of nursing homes, and this of course contributes to all these infections and contributed to the pandemic. Next slide. Also, I want to mention the federal staffing requirements. They are so minimal, and as Lori said, we fought for years to get a decent minimum staffing level. It's only required to have one RN on duty 8 hours a day, 7 days a week, and of course the director of nursing. And then to have a licensed practical nurse or a vocational nurse on evenings and nights. But the federal requirement is that each nursing home must have sufficient nursing staff to assure resident safety and to attain or maintain the highest practicable level of physical, mental, social, psychosocial well-being for each resident. So this basically means that nursing homes are to determine what their resident needs are and to staff to meet those needs. So they have to adjust based on the resident needs. So many states have their own requirements, and California has a 3.5 overall nursing hours per resident per day requirement with lots of waivers. And of course, it's a very insufficient standard. Next slide. So the aim of our study was to look at what factors impacted on whether or not nursing homes had residents with COVID-19 infections. And our hypothesis was that nursing homes would be more likely to have COVID resident outbreaks if they had lower RN and total staffing, more deficiencies and more infection control deficiencies, and if they were for-profit in ownership and had more nursing home beds, because if you have more beds, there's more exposure to potential infections. Next slide. Our methodology was to first identify which nursing homes were reporting COVID resident infections. And we used the California State and the Los Angeles County Department of Public Health reports, and also looked at news media reports for the period of March 15th to May 4th. And we found 272 nursing homes, or 26%, reported COVID-19 residents out of about 1,000 nursing homes. We didn't look at the number of infections or the deaths because we were concerned about the accuracy of the data that we had. And we obtained all of our data for the analysis from the CMS Medicare Nursing Home 5-star databases. Next slide. Okay. We looked at 3 different nurse staffing measures separately to see which ones were important. The first was just to look at RN and total hours per resident day. The second measure was actually to look at what the recommended standard hours per day would be. And this is based on the CMS 2001 report. And that report recommended a minimum of 0.75 RN hours for long stay residents and a minimum of 4.1 total nursing hours per resident per day. And the third measure of staffing we used was looking at the CMS ratings for RN and total staffing on the Medicare Nursing Home Compare website. And these ratings are different from the other measures because they're based on what CMS calculates. The expected staffing should have been adjusted for the acuity of all the residents in each specific facility. So we analyzed these separately. Next slide. So our findings were that 80% of California nursing homes did not meet the minimum RN standards of 0.75 hours per resident per day, and 55% did not meet the recommended minimum of 4.1 hours per resident per day. And we found that nursing homes with low RN and total staffing, they were associated with facilities that had more total deficiencies, more infection control deficiencies, if they were for-profit owners, and if they had a large number of beds in the facility. And they were more likely to have COVID-19 residents. Next slide. So when we put all of these factors into a regression analysis, we found that nursing homes were more likely to have COVID-19 residents if they had RN staffing less than 0.75 hours per resident per day. In fact, they were 2 times more likely to have infection outbreaks. The total staffing of less than 4.1 hours per resident per day was not significant when you control for these other factors. Also, looking separately at the 5-star ratings, we found that low RN staff ratings and low total nurse staffing ratings were significantly related to whether or not facilities had the resident outbreaks. And facilities that had more federal deficiencies, and we looked at infection control deficiencies separately, and both of them predicted facilities would be more likely to have COVID-19 residents. And of course, large size facilities were more likely to have outbreaks. And when these factors were all put in the model together, for-profit nursing homes were not significant. We also did a separate analysis for Los Angeles County, because Los Angeles County was what we call a hotspot. It had very large numbers of COVID-19 in the population. And when we looked at LA County separately, we found that they had similar findings. Next. So of course, there were a lot of limitations to the study. We were only looking at one state, but we do think California is typical of other states in terms of its staffing. We also know that the COVID-19 infections may have been underreported, and of course there were problems with accuracy in reporting. And this was early in the pandemic, and California didn't have as many nursing homes with infections as some other states, such as New Jersey. And we weren't able to look at the residents that were racial or ethnic that had racial or ethnic minorities or were on Medicaid. Next slide. So the implications for policy, we think that there's a clear need for higher RN and total nurse staffing levels in nursing homes, and that this study verifies the importance of having minimum standards, especially the 0.75 RN standard. These standards were made over 20 years ago in research commissioned by CMS, and they've been verified in various research studies and by expert opinion, and also by professional and consumer organizations, including Consumer Voice. We also think it's important to look at the 5-star ratings for staffing, because those ratings do adjust for resident acuity, whereas of course just having the flat minimum doesn't take into account acuity. And we'd like to see CMS and the states start enforcing these standards, because we think it could make a big difference in preventing infections and all the quality problems that we see in nursing homes. And so we'd like to see states and CMS set a higher minimum staffing standard. Next slide. In terms of implications for practice, we know that nursing homes generally substitute licensed practical nurses for RNs to save money, but only RNs are specifically trained in infection control. They're trained in resident assessment and in identifying and treating infections and surveillance of residents and resident care. So they, in all of the research studies, they always show to be an important factor. And we also think that it's important that we get the word out that consumers and discharge planners and case managers need to use the Medicare nursing home compare ratings to choose the highest quality nursing homes, because we know those are associated with less infections and lower mortality rates. So if a nursing home has a 4 or 5-star rating, it doesn't necessarily mean that that nursing home is wonderful, because nursing homes are graded on the curve. But if a nursing home has a 1 or a 2-star rating on staffing and overall rating, we know that facility has problems. Next. Okay, in terms of future studies, we think there was a lot to be studied in terms of the relationship of these infections to some of the working conditions, particularly wages, health insurance benefits, sick leave, turnover, training levels, and nursing staff who work in multiple facilities. Of course, we really don't know much about the testing use and availability and the PPE use and availability. So more studies in that area. And then we'd like to see more studies on Medicaid and racial and ethnic minorities. So I'll stop there and thank you very much.
Thank you, Dr. Harrington. We'll now turn to Dr. Lee.
All right. Hello, everyone. So first, I want to thank the National Consumer Voice for Quality Long-Term Care for organizing this webinar today. So my name is Yue Li. I'm a professor of health policy and outcomes research at the Department of Public Health Sciences, University of Rochester. Today, I will present the study we just published last month in JACS, the Journal of the American Geriatric Society, which examined the COVID-19 infections and deaths among Connecticut nursing home residents and the potential impact of nursing home characteristics, such as nurse staffing levels and overall quality of care. Next slide, please. I really want to thank all of my co-authors on this study, Dr. Helena Temkin-Griner, Ms. Shen Gao, and Dr. Shoya Kai. We're all from the University of Rochester Medical Center. Next slide. So long-term care residents are at the highest risk of severe COVID-19 infections because of their advanced age, frequent and complex chronic disease patterns, and highly impaired physical, cognitive, and immune system functions. The first COVID-19 case in nursing home of the United States was identified in a skilled nursing facility in Seattle, Washington on February 28th. Since then, the novel coronavirus has spread rapidly in long-term care facilities over almost all states. According to a recent report of the Kaiser Family Foundation, by July 9th, there were over 11,000 long-term care facilities in 44 states that had reported at least one COVID-19 case. The total number of cases in long-term care facilities was over 283,000, and the total number of COVID-19 deaths was over 56,000. Nationally, 12% of all COVID cases are reported as being in long-term care facilities, and 44% of COVID-19 deaths occurred in long-term care facilities. Next slide. The current nursing home literature suggests strong evidence that higher nurse staffing levels in nursing homes, especially higher registered nurse hours, improve safety of care and resident outcomes. Residents in nursing homes with better quality of care also tend to have better health outcomes, such as lower rate of pressure ulcers. In addition, it is widely reported that nursing homes caring for a disproportionately high number of Medicaid residents or racial and ethnic minority residents tend to have very limited resources, which lead to poor quality and safety outcomes for their residents. Next slide. So to give you a little better sense of this quality and disparity issues highlighted in the nursing home literature, this is another study we published several years ago, which looked at the number of deficiency citations in nursing homes and trend in racial and ethnic disparities from 2006 to 2011. Next slide. This is the key result from this study. So from 2006 to 2011, nursing homes with high or medium-high percentages of racial and ethnic minority residents had persistently higher number of deficiency citations than nursing homes with medium or low proportions of racial and ethnic minority residents. Next slide. In a separate study that Charlene and I published, we also tracked the trend in nurse staffing hours in nursing homes over time. Next one. So this is the trend in RN staffing hours per resident day from 2001 to 2011, and by nursing home groups with low, medium, high, and high proportions of racial and ethnic minority residents, which were defined based on quartile groups. So again, we see persistent disparities in RN staffing, in which nursing homes with higher proportions of minority residents had lower RN hours. Next slide. So informed by the current nursing home literature, we did two things in this COVID-19 study. First, we described the variations in the numbers of COVID-19 confirmed cases and deaths among Connecticut nursing home residents through April 16. And then we determined how these variations might be associated with the key nursing home characteristics, including RN staffing level, overall quality of care measured by the 5-star ratings of the nursing home, the proportion of Medicaid residents in the nursing home, and the proportion of racial and ethnic minority residents in the nursing home. Next slide. So we downloaded the data that were publicly reported by Connecticut Department of Health and Human Services. Connecticut is among the several states that started reporting nursing home COVID-19 data as early as in the middle of April. So another state doing so is California, as Charlene just presented. The first report in Connecticut includes numbers of lab-confirmed COVID-19 cases and deaths in each and every nursing home in Connecticut as of April 16. And the data are very complete because all nursing homes in the state are included in the report, and the numbers are updated on a weekly basis. Next slide, please. We linked the COVID-19 data from Connecticut to the nursing home compare file in order to define staffing quality and other nursing home covariates. Next slide, please. We also used several other data to define nursing home as well as county variables. So I list all of the data here, although I won't go through the details given the time limit. So next slide, please. So statistical analysis. In the analysis, we examined the distributions of the number of COVID-19 cases and deaths over nursing homes and the distribution of nursing home characteristics as well. We also summarized the number of COVID-19 cases and deaths in all counties in Connecticut. In the multivariable analysis, we fit the two-part models for count data with a large number of zeros. I mean, 0 case in the nursing home or 0 deaths in the nursing home. Next slide, please. So this is the characteristics of nursing homes by the number of COVID-19 cases. Among the 215 nursing homes in Connecticut, 107 had 0 cases by April 16. 45 nursing homes had between 1 and 10 cases, and 63 nursing homes had between 11 and 69 cases. The average number of confirmed cases is 0, of course, in the first group, 5.2 in the second group, and 23.5 in the last group. The number of confirmed deaths is 0 in the first group, 0.9 in the second group, and 5.3 in the last group. RN hours are also higher in the first group of nursing homes with 0 cases, 0.8 hours per resident day compared to 0.6 hours per resident day in the other two groups. Also, 62.6% of nursing homes had 4 or 5 stars in the first group with 0 cases, while only 45% and 42% of nursing homes had 4 or 5 stars in the other two groups. There are also other important trends in the table. So nursing homes with more confirmed cases tend to have a higher percentage of Medicaid residents and a higher percentage of racial and ethnic minority residents. They also tend to have more beds with more residents and are more likely to be for-profit nursing homes affiliated with a chain. The next slide. So this table shows the characteristics of nursing homes by COVID-19 deaths. Among the 215 nursing homes in Connecticut, 131 had 0 deaths by April 16. 61 nursing homes had 1 to 5 deaths, and 23 nursing homes had 6 to 15 deaths. So the trend in RN staffing, star ratings, and other nursing home characteristics over the three groups are very similar to what we just saw in the previous slide. Next slide, please. So for each of the 8 counties in Connecticut, we calculated the proportion of COVID-19 confirmed cases who were nursing home residents, which is the plot on top with the blue color. So in Connecticut overall, 11.2% of the COVID-19 cases were nursing home residents, but this number ranges from 0 for the county of Windham to 19.5% for Toland County. So the red bars at the bottom are the proportions of COVID-19 deaths who were nursing home residents. The last column shows that in Connecticut, 38.7% of the COVID-19 deaths were nursing home residents. And this proportion varies from 0 for Windham to 50% in Toland County. Next slide, please. So in figure 2, the scatter plot with blue color demonstrates the predicted number of COVID-19 cases in each nursing home against the RN hours per resident day in the nursing home. So there is a clear trend that as RN staffing increases, the number of cases goes down, and the p-value suggests that the association is statistically significant. So in a similar way, the scatter plot at the bottom shows that higher RN staffing was associated with fewer COVID-19 deaths in the nursing home. Next slide. In figure 3, the blue bars on top are the predicted number of COVID-19 cases by nursing home 5-star ratings, so 1 to 3 stars versus 4 or 5 stars, by percent of Medicaid residents in the nursing home, high versus low, and by percent of racial and ethnic minority residents, high versus low. Clearly, so 4 or 5-star ratings had fewer cases than 1 to 3-star nursing homes, and nursing homes with higher percentage of Medicaid residents or higher percentage of minority residents tend to have more cases. So similar trends were found for the number of COVID-19 deaths at the bottom, although statistically the differences were not significant. Next slide, please. So just a summary of what we just saw in the figures. So by April 16, this study found that by April 16, COVID-19 cases have been found in 50% of all Connecticut nursing homes, and deaths is found in 40% of Connecticut nursing homes. The data strongly suggest that higher RN staffing help reduce virus transmission and resulting deaths. So our models estimated that among nursing homes with at least 1 confirmed case, every 20 minutes increase in RN staffing hours was associated with 22% fewer confirmed cases. Also, among nursing homes with at least 1 COVID-19 death, every 20 minutes increase in RN staffing was associated with 26% fewer COVID-19 deaths. Next slide, please. We also found that the higher quality ratings of nursing homes predicted fewer confirmed COVID-19 cases and potentially fewer deaths as well. And finally, nursing homes caring predominantly for Medicaid or racial and ethnic minority residents tend to have more confirmed cases and potentially more deaths as well. Next slide, please. Some discussions. So starting in early March, CMS has released a series of guidelines, such as visitor restrictions to fight the surge of COVID-19 infections and deaths in long-term care facilities. The CMS and most states also refocused their on-site inspections of nursing homes on compliance with infection control standards. These refocused inspections initially targeted nursing homes in several hotspot areas or nursing homes with no infection control deficiencies. So our results suggest that going forward, CMS and state nursing home inspectors may target more broadly those facilities with lower RN staffing levels and lower quality ratings, where the transmission of virus is more rapid and more deadly. Also, current federal regulations require nursing homes to have the RN on duty at least 8 hours a day and 7 days a week. So although this staffing requirement might be hard to raise nationally, the nursing homes that are able to increase their RN hours should consider doing so for more effective control of COVID-19 outbreaks. And finally, throughout the COVID-19 pandemic, nursing homes caring mostly for Medicaid or racial and ethnic minority residents have constrained resources and therefore are more likely to experience severe shortage of staff or shortage of PPEs and other medical equipment. So national and local efforts to boost their healthcare capacity in nursing homes should target these facilities and address these issues of disparities among nursing homes. So next slide. Thank you all. Now I'll turn it to Robin.
Thank you so much, Dr. Lee. And actually, I want to give a big thank you to both you and Dr. Harrington for this incredibly timely and valuable research that shows us, once again, how important staffing levels are. I will always remember when I first started as Director of Public Policy and Advocacy, and this was in a time before COVID, the head of the CMS Division of Nursing Homes asked me what I felt were the top 3 factors that contribute to the most to quality care. Next slide. And that was my answer. My immediate response was number 1, staffing, number 2, staffing, and number 3, staffing. Over the past 25, 30 years, there have been more than 100 research studies that have documented this important relationship between nurse and nursing assistant staffing levels and the outcomes of care. And I know that all of you on the call today know very well the problems that result from inadequate numbers of staff. And just to name a few, higher mortality rates, decreased physical functioning, more pressure ulcers, more urinary tract infections, more weight loss, dehydration, and the list goes on. And now, thanks to the research by Drs. Harrington and Lee, we also know that there's a relationship between staffing and COVID in nursing homes. So as both Lori and Charlene noted, Consumer Voice has advocated for adequate staffing literally for decades. Next slide, please. And as you've heard, we've advocated for the presence of a registered nurse 24 hours a day, since the current requirement is only 8 hours a day. And we've advocated for a minimum staffing standard of at least 4.1 hours of direct care nursing time per resident per day. Some of you may actually remember our slogan, which at that time was 4.1, it can be done. Well, I guess I would put out there to all of you today that not only can it be done, but it must be done. Advocacy for specific staffing requirements to increase overall staffing levels has always been critical, but with COVID, it's taken on, I think, an absolute urgency. We have to have increased staffing to prevent, delay, and manage COVID now and during any second wave. We have to have it to prevent, delay, and manage future infectious diseases, because sadly, this will, I'm sure, not be our only pandemic. And we have to have increased staffing to make sure that residents receive the care and support that they need every day, with or without COVID in facilities. But this is the care they need to thrive and quite frankly, just to survive. So what can we do right now to move toward and achieve increased staffing levels? So the answer is that you can advocate in your state and with members of Congress. Next slide, please. So first, if you haven't already spoken with your state and federal legislators about staffing, start there. Educate them about the importance of staffing. Tell them how residents are suffering during the pandemic due to lack of staffing. But I also think it's essential to point out that the harm that residents are experiencing because there aren't enough staff underscores a long-standing problem, one that has to be addressed if we're to stop residents from suffering and dying, and not just suffering and dying from COVID, but from lack of care. Share your personal or your professional experiences and observations with your legislators and tell your story. You cannot ever underestimate and undervalue the importance of your own story, particularly when you are a constituent and you are talking directly to your legislators. Next slide, please. And second, make what is often referred to as the ask. And this is what you specifically want the legislator to do. It's really important to be very clear and very specific about what you're asking them to do. So for your state legislators, just come right out. Ask them to introduce legislation requiring nursing homes to have at least 4.1 hours of direct care nursing per resident per day and an RN round the clock. As a constituent, you absolutely have the right to ask your legislator, to draft legislation. For members of Congress, request that they support an act that is right now in Congress. It's called the Quality Care for Nursing Home Residents Act. It was introduced by Congresswoman Schakowsky in the House and by Senator Blumenthal in the Senate. Next slide, please. So this bill does exactly what we wanted to do. It requires 4.1 hours of direct nursing care per resident per day, and that is broken down by category of nursing staff. So for instance, RN, LPN, CNA. It's broken down by shift, and it's expressed both in terms of hours and a ratio. And because there has to be RN coverage every shift, this bill would result in the presence of an RN round the clock. There are many provisions in this bill that would really do a lot to improve quality care. And just one other example is it mandates 2 new nursing positions, that there would have to be an assistant director of nursing, and there would have to be a director of in-service training. And it does other important things like increasing the initial training for CNAs. But for our purposes right now, it is exactly what we are advocating for in terms of staffing. And I would say that that's not a coincidence. Consumer Voice, along with other advocacy groups, work directly with the Congresswoman in drafting this bill. So we're very excited that it exists. and that it's been introduced. But that's just the beginning. So what we will need is for all of us to really, do the work. We know what we want to advocate for, but we also know, and I just want to be really upfront, that this advocacy won't be easy. Next slide, please. We are going to need to be more persistent and more tenacious than ever. But we're good at persistency and persistence and tenacity, right? I think that's actually built right into the definition of an advocate. But this is a battle. It's a hard one. Obviously, if it were easy, we would already have good staffing standards in nursing homes. So it's a hard one, but we can do it. We need to keep at it, and every single one of us needs to be engaged. And we have to advocate, I think, like never before. The COVID crisis has really shown us very starkly that having enough staff is a necessity. We knew it before. The crisis has just shown it, it just amplified the importance of having enough staff. And we need to just put right out there that it can no longer be acceptable for nursing homes to understaff, period. So I'm just gonna leave you with this. If there's ever been a time for all of us to go to the mat and advocate at full force, this is it. Next slide, please. Because if not us, then who? And if not now, then when? So I'm going to turn it back over to Lori.
Thanks, Robin. And thank you to Dr. Harrington and Dr. Lee, all three of you, for your excellent presentation. Certainly have given us a lot of food for thought. There have been a lot of questions coming in, and certainly has really highlighted the need for continued work around increasing not only levels of staff, but even particularly the presence of registered nurses in long-term care facilities. That is certainly a very critical component. And as we move into the question phases, Jocelyn and Sam are getting some questions ready. Next slide, please, Libby. I'd like to remind you that there are a number of resources, go back one, please, on the Consumer Voice website around COVID, around issues related to that, the guidance from CMS, advocacy strategies, and we also have on our website a lot of information about staffing and the importance of this issue, and bullet points and talking points on what you can use to be advocating for it. And next slide, please, Libby. And during this time, as we're moving through the pandemic, we are also asking you to share your personal stories about how you and your family are impacted by COVID, and we have a place on our website to do that. So next slide, if we can go to some questions. We'll use the balance of time. We have about 10 minutes left to get to as many as we can. So Jocelyn and Sam, can you queue up some questions for us, please?
Sure. We got a lot of great questions, but I just wanted to start out with one that I think is useful for everyone. Someone asked how consumers can find out about staffing information in their own states.
So there are a number of different ways. One of the best ways is by looking at the staffing data that facilities are required to submit. And this is referred to as the PBJ data, the payroll-based journal data. So that shows, actually it shows the data by facility. So you can actually drill down to that level, and then you can sort it in different ways. So you can see what staffing is at the state, And you can also see what it is, as I said, in a region. So there are different ways to kind of slice and dice it. But that would be the best place, I think, to go to find out staffing information.
I think certainly about as Robin mentioned, that will get you the staffing levels that are being reported in the facilities, but also educate yourself about what your state requirements are around staffing standards. Most states do not require the staffing levels that have been talked about by Drs. Harrington and Lee today. So next question.
Sure. Quite a few people had questions about earlier studies, specifically one by David Grabowski that said that neither nursing home quality nor staffing were important predictors as to COVID in a facility, but it was more based on community, the community level presence outside the facility. How can what we've talked about today be explained in comparison to those studies, or to that early study?
Dr. Harrington, could you take a first stab at that?
Well, I think the earlier studies looked at data across a lot of states, and there's so many differences in the way the states report their data. For example, New York doesn't report data unless they've had 5 deaths in a nursing home. So I think by putting all these states together with such mixed reporting, that it didn't come out as well as it should have. So I would turn to Dr. Lee, because he's doing some more new research on the national data.
Yeah, thank you, Charlene. So right now the CMS is publishing the COVID-19 data for almost all the nursing homes in the nation. Those are the new requirements for nursing homes. So beginning in the May of this year, all nursing homes are required to submit their COVID-19 data to CDC, which allows CMS to publish this data. We had kind of follow up a study on this national data and found that even after controlling for the county level COVID-19 cases and number of COVID-19 deaths, the 5-star ratings and nurse staffing levels are important predictors of the numbers of cases and COVID-19 deaths in the nursing home. So I think some of the stats, as Charlene mentioned, published the early data nursing homes, but the the numbers are really sometimes it's hard to say they're reporting the data in a very accurate way. So it's hard to say in New York State, for example, yes. So they don't report the number of cases; they only report number of deaths for nursing homes that had 5 or more deaths. In other states, they only report the data for maybe nursing homes with 5 or 10 or more beds. So for smaller nursing homes, we don't know the situation at all. So that's probably the issue of the data in the early period of reporting. So I hope that with the national data, we we have a better data and better evidence for these important predictors of nursing home COVID-19 outbreaks.
Thank you to both of you for your responses to that. And I think it certainly, as you're both saying, highlights the need for continued and ongoing data and data collection for sure, ensuring that we are having accurate data collection, but also continued research in these areas. There's much, much more I think that needs to be done. And, you know, I think as we also look at the factors around COVID and the incidences that we're seeing in long-term care facilities, certainly prevalence and community is a factor, but I think, you know, there are steps that need to be taken to keep the virus out of nursing homes, but then there are also critical issues with respect to how it's handled if it does enter a nursing home. And I think clearly the data shown and the research shown by Drs. Harrington and Lee show that not only is staffing critical for addressing the needs of the residents, but having RN presence is very critical as well. So another question, please.
Sure. To what you just said about RN presence, we had a few questions about CNAs and RNs. So one question was whether or not the researchers can speak to the idea of training personal care attendants or CNAs to undertake certain RN tasks versus hiring more RNs, and which option may be more efficient and cost effective at improving patient outcomes. And then going along with that, another question was what specific practices or approaches completed by RN staff do the researchers think result in lower infections and deaths in nursing homes?
Well, this is Charlene. Well, RNs are the only ones who are trained to do resident assessments. They're the ones who can determine if someone has an infection or a stroke or has had a heart attack or injury and has been injured. And they're the only ones who have really been trained in infection control. So no, there's no way to substitute LVNs or other personnel for RNs. We have to have enough of those. But of course, we need to have enough direct caregivers too. I mean, because if a nursing assistant should only have should only have 5 to 7 residents at the most to take care of. If they have more than that, they are rushing from resident to resident to get the care done, and the work doesn't get done, and they often don't wash their hands, and they don't have time to practice infection control. So you need to have both of those things.
Thank you. Next question.
There was some questions on these studies focusing on RN levels. Is there any additional information on CNA staffing levels?
Well, the latest research shows that they shouldn't have more than 7 residents to take care of on the day or the evening shift, the CNAs. And if there's high acuity, they should only have 5 residents. Many nursing homes have 10, are assigning 10, 12, or even 15 residents to a CNA, and that's just impossible. That's why the care is so poor.
Mm-hmm. Thank you. Next question.
Sure. Going along with that question, is there research on CNAs in terms of their training and turnover, degree of supervision, anything sort of looking at that and whether or not they're working in more than one facility and how that plays into some of these outcomes?
Yes, we know that in some cases, at least 20% of nursing assistants are working in more than one facility, more than one job. And that's because the pay is so low. It's minimum wage pay. They usually don't have sick leave and they don't have health benefits. And so there's high turnover rates because of the low pay and the stressful working conditions. So we know all of these things from previous research. The issue is how do you get nursing homes to raise the pay so that they can stabilize their nursing staff, including the CNAs and LVNs and RNs. And that's a problem when you have for-profit nursing homes. The major way they're making money is by cutting on staffing.
Thank you. And I think we have time for one more question.
There was a question as to could the higher levels of RN hours just indicate better management or better investment in the facilities, and therefore a better care all around? And can you control for that to show that it was actually the RN hours that increased positive outcomes?
Well, this is Charlene. We know from the research that the RN hours are the most important hours. But yes, I think having more RNs is also going to lead to better management, better competency in the overall facility. And so it has many benefits. And because there are many other factors that are important for high quality care, but our concern is that if you don't have at least a minimum number of staff, then you can't improve on these other, on the training and competency and consistency of staffing.
Mm-hmm. And I think that those are great words to end today's program with. Obviously, there's a lot of interest in this issue, and unfortunately, we weren't able to get to more questions today. Just a reminder that the recording and the slides will be emailed out to those who've registered and will be available on the Consumer Voice website. I'd like to give a great thanks to Drs. Harrington and Lee for their excellent presentations and for the research that you're doing, which is so not only timely, but so critically important for highlighting what some of the biggest issues are and some of the needs are and how we can protect residents and move forward and what we need to be doing in order to do that. It obviously, as I mentioned, shows the great need for additional research in this area. And for those of you that are researchers on the call, I hope that you will consider taking up more of an interest in this area and looking for opportunities to engage in research. And we at Consumer Voice would be happy to talk to you about that. And I'm sure that others that have been speaking today would be willing to talk to you about that as well. So with that, I'd like to thank you. We'll look to do more programming around this issue in the future. And thanks to Robin for her excellent advocacy tips, and to Libby, Sam, and Jocelyn who were helping with questions in the back end today. And so thank you. That closes our program for today, and have a good rest of your afternoon.